So B8 is not a whole lot different from the current version in UDS3, but it was expanded a bit to be a little bit more inclusive. So the purpose of this form is to assess the presence versus absence of neurologic signs and rate the degree or the topography, meaning is it unilateral or bilateral of any of the clinical findings. So this form is to be completed by the clinician with experience in performing a comprehensive neurologic exam, and this is all laid out in the coding book. Plus, it is strongly encouraged that the clinician should have experience in completing a full neuro exam. There are 3 pages to the neuro exam form, and just to go through these individually, again, the top of the neuro exam form, the mode and key. You can record findings remotely by video on this form, again, realizing there's certain elements such as rigidity or postural instability via the pull test you can't do by video. And so you would just put not assessed for those individual items. But there's a lot you can do by video. But for everyone who's been seen in person, hopefully a comprehensive exam will be done. So that is the preferred mode. A comprehensive neuro exam is done on every participant at every visit. If there are certain circumstances one cannot do a neuro exam, the 0 is checked, or if a partial or a focus exam is done in person or via telehealth, that's checked, depending on particular circumstances. And just like with the UPDRS, if the exam is fully performed and it's normal, you check the no abnormal finding box here and you're done. If there are any exam findings, then there are some other gateway questions. And there's 3 sections to this: Parkinsonian signs, cortical and pyramidal and other signs, which are shown in a minute, and then gait. Within the Parkinsonian signs, this is also a gateway question. If there are no elements of Parkinsonism, one can hit the no abnormal signs here, and you're done with this section, and all of these will default to absent or 0. If any are positive, you check yes, and then you check the appropriate findings. So the findings are a little bit different from the way they're recorded in UDS3. So instead of present and then right or left, there were many who thought right versus left really doesn't matter. It's more, is it focal or unilateral, or is it bilateral? And if it's bilateral, is it asymmetric or symmetric? And so that's why the responses are laid out in that way for these exam findings. And then for others, it's more just present or absent. And importantly, and this depends on how diligent one wants to be, but for the diagnosis of Parkinson's disease, then one has to have bradykinesia with decrement. And decrement is defined by the repeated AMRs if there's a decrement in amplitude after the first several attempts. And many people will do AMRs at least 10 times. And if you see a decrement in amplitude, then that would be check yes. So again, the format a bit expanded for some of the elements, just absent or present or not assessed in others. The next section is the cortical, pyramidal, and other signs. If all of these are absent, then you just check no and you're done with this section. If any are positive, you check yes. These findings have this similar way of recording responses: limb apraxia, face or limb findings in upper motor neuron distribution or lower motor neuron distribution, visual field cut, limb ataxia, or myoclonus. And then these are more present or absent: somatosensory loss, aphasia, alien limb, hemispatial neglect, prosopagnosia, simultaneous agnosia, optic ataxia, apraxia of speech. For gaze palsy, many older people have a restriction in up gaze, and we're asked not to record that as abnormal. So if it's a down gaze abnormality or horizontal gaze restrictions, then that's recorded as present. Dysarthria is recorded, and apraxia of speech. And then the final aspect is just like in the current form, gait, normal or abnormal. If it's abnormal, you record the characteristics of the gait. And then this was added just as an FYI, and some sites are already doing this or may want to do this, depending on the presence of any of the neurologic findings. So if there are any elements of Parkinsonism, one could do the UPDRS, which is being done already, or the MDS UPDRS. Any elements of ALS, one could complete the ALS functional rating scale revised. This is a very quick scale to do. Any features of PSP-Richards syndrome, the PSP rating scale, corticobasal syndrome, or PSP rating scale, the corticobasal functional rating scale. There are some groups that are focused on atypical variants of Alzheimer's disease where there's a PCA battery, and that could be done to better characterize elements of posterior cortical atrophy. And then if there's elements of aphasia or apraxia of speech, then NIH stroke scale, progressive aphasia severity scale, Western aphasia battery, and so forth. And then if there's any vascular contributions, same thing, stroke scale or the Hutchinski. So this will be up to the site if they want to or already doing these additional measures. And then there is a glossary on that last page. So the key points with this form, the formatting is a little bit different. It's organized into a Parkinsonian section, cortical pyramidal other science section, gait features section with gateway questions for each one. Some of the potential clinical signs, the responses are expanded, and the expansion has gone from right left to, as shown here, focal, unilateral, bilateral, and symmetric versus asymmetric. So again, to emphasize, a full neuro exam is expected on all participants when evaluated in person. And typically, again, a full neuro exam can usually be done in less than 5 minutes. Complicated patients, it can take longer, obviously. And then the B8 form, normal exam, it'll take 5 seconds. If it's abnormal, it'll take a little bit more time, but still a complicated exam won't take long to record on this form. And for this, there's no formal certification required, and please just refer to the guidebook for the neuro exam itself. And we'll stop there, and happy to take any questions.
Yeah, there's some in the chat, Brad, about attributing causality to the UPDRS. Would there be value to let the evaluator comment if they think it's related to Parkinsonism or something else?
Yeah, again, there's 2 ways to record the UPDRS, and we decided as a group to follow the recommendations of the MDS UPDRS. And you can see where this is a bit of a quandary. If we're going to do a cross-sectional analysis of data, it's going to be contaminated by musculoskeletal and other contributions. However, if people are doing a longitudinal assessment, you want that per person already factored in, because they may have an elevated score that isn't Parkinsonism. It may be musculoskeletal, or at least contributed by that. And if that worsens over time, that would suggest worsening Parkinsonism. So again, there's pros and cons with each one, but it is preferred to rate what you see. And then, John, can you do a comprehensive neuro exam by video? A lot of the exam you can. The only thing you just can't record, just to check not assessed, would be for things like rigidity. Anything you got to put hands on and do deep tendon reflexes or Babinski sign, you'll have to say not assessed. But those things you can assess by video, then that would be okay. By phone, I'm not sure how you do that, but probably not.
Looks like a couple people are asking for you, Brad, to make a video for us.
And actually, we have talked about doing a training video of a full exam, and we can certainly do that.
That'd be a great resource.
Yeah. The video for the UPDRS, again, that's very well done, and that's the reference for the UPDRS, but we can do a video for NACC purposes for the full exam.
And then the question about whether UPDRS includes the participants on or off levodopa, I think that would be captured in the medication forms, right? So
Right, but that's a good question, because in the MDS UPDRS, you're supposed to record the dose and the timing of the last levodopa or dopaminergic agent, and that's not recorded when we do the UPDRS. So again, it's the downside of doing the traditional UDRS, but at least we'll record, is the person on dopaminergic agents, even if we don't know the timing of the last dose. See, should the exam be done the same as UPDRS as? I'm not sure if I understand that question. Should the neuro exam be done the same as UPDRS as what? Oh, I see. So you rate what you see. That's a good question. Traditionally, we've rated what we see that we believe is CNS related. And so I guess the best answer is, if you would call that person as having a gaze palsy, even if they have existing ocular problems that are more ocular as opposed to brain related, I'd want to record to the best you can, is that a CNS problem? And also a reminder for those who do see a fair number of Lewy body disease patients or FTLD patients in those respective modules, there's a bit more characterization, especially in the Lewy body module. So if you really want to get into details, then that module is worth completing, realizing it is additional work. But another factor for UDS4, it was expanded a little bit to better capture outside a little bit of the traditional AD-centric features and findings. So John's saying, I would suggest you do a visit by phone to default to no neuro exam. I would agree.
yeah, and we'll clarify that in the guidebook. Thank you for that, John.
Yeah.
This might be a good point just to ask people, I think we've had some good suggestions. People have asked about the paired non-MCI, which we do a video on, the MBI webinar. Brad got voluntold to do one on neuro exams, and we'll have the UPDRS link. If there are other suggestions, we can gather thoughts on other videos or webinars that would be helpful. Please put that in the chat. And then I know Marcella had asked earlier during the break about whether we'd have other opportunities to ask questions, and we will circulate that. We'll have, in response to the pilot testing, we'll have other opportunities for people to submit questions, concerns, and then, as we've mentioned at several meetings, we'll have some kind of open office hours we'll schedule where we have someone from the clinical task force, someone from the NACC kind of data side, to be able to answer questions as you start using these forms in real time. So we'll have some other opportunities, and we'll gather common questions for FAQs and/or make sure we revise the guidebook, please.
It may be one other request. A lot of neuro groups have their own in-house batteries that teams will do. So for example, we use this set of faces to assess proceptive agnosia, or these complex pictures to assess simultaneous agnosia. As long as they're not published and they're shareable, it would be great to share with a greater ADRC network. So.
Let's see, maybe the NACC team, so it's the question about. Because we had the TCOG for a while during COVID, whether we'll be allowing teams to put in the UDSv4. I guess I don't understand why a neuro exam would not be conducted if they're having in-person neuropsych testing, that there should be a clinician available or schedule when a clinician could do that. Other thoughts from the group?
Yeah, again, the preference is for any in-person visit to have a neural eval, realizing there can be scheduling challenges at times.